outcome? That is the first thing that we should answer. Does it improve outcome? Okay, that's the first thing. Okay, and personally I feel if there's something that has improved outcomes in mechanical ventilation, if there's something in this world that has improved outcomes when it comes to mechanical ventilation, it has been non-invasive ventilation. There's nothing better than non-invasive ventilation. So when I did my medicine, it was very difficult for me to actually understand how to save patients. It was very difficult because you put them on an invasive ventilator, they would kind of go down. Long ago it was like this, you put them on an invasive ventilator, they will die. They will die. So I've worked with the ventilators which didn't have all these microprocessors that you're dealing with. So we had very basic ventilators which used to be piston driven and things like that, which were very difficult to manage. It was very difficult. All patients used to be on very long-term paralysis, and it used to be very difficult managing these patients. Now we have come to a condition where we are no longer using just simple just AMBU type devices. We have started using microprocessor guided ventilators, which has made ventilation very simple. But that also is dangerous. What is best is to avoid that in the first place. What is best is to avoid invasive ventilation in the first place, and I think the way to do that is by non-invasive ventilation. Okay, and I think it does improve outcomes, no doubt about it, improve outcomes. In fact, I have been writing everywhere in all papers, every time I've been putting it this way that that kind of improves, non-invasive ventilation is the way to be done. And when one person asked me in one of the TED Talks, I was part of a TED Talk recently, and they asked me if there's something that changes medicine, what is it? And I said it is non-invasive ventilation, the whole medicine itself. In the whole medicine itself, if there's one thing that's changed something, it's non-invasive ventilation because it's improved outcomes. And this is not from now, it's from a way ago. It's like, this is the data that is almost 30 years back. Many of you wouldn't have been caught into medicine at this time. Some of you may not be born also. Okay, so that matter. Okay, so at that time, there were very famous people called as Andrew Bernstein, Laurent Brochard. These people now also they are alive and they are fantastic physicians and intensive care pulmonologists that actually invented this thing called as non-invasive ventilation. It was a surprise for them because what they found was something very interesting. So if you look at the data there on top, okay, what they say is they looked at all patients. That was the 7 patients that they put on mechanical, 20 plus 19 patients that put on mechanical ventilation, of which some of them were just CPAP versus oxygen. CPAP versus oxygen. Okay, they give some pressure versus just normal oxygen. And what they found was 7 ventilators, the in-hospital deaths were kind of lower when it came to CPAP plus oxygen. In fact, mortality was also low. Everything was perfect. The hospital stay, actually everything improves. That way, there was a clear improvement in those patients who required mechanical ventilation. For example, here, look at this, the treatment group was only 1 needed intubation, whereas 11 out of them needed intubation when it comes to non-invasive, when you're not using non-invasive ventilation. You're understanding? So if you used non-invasive ventilation, what they found was they were able to avoid intubation. They were able to avoid invasive mechanical ventilation, which actually kind of improved mortality, improved the stay in the ICU and things like that. So long ago when this person, Gianfranco Umberto Meduri, is actually known for his use in steroids. If tomorrow you're going to read any topic on steroids, it will be, you will always hear the name Meduri. Meduri is the person who's been dealing with steroids all the time, but he's also credited with the fact of using non-invasive face mask ventilation when it came to patients with acute respiratory failure, not only to prevent intubation but also to reduce PaCO2 in patients of COPD. That's what you're seeing here. See what happens in COPD? It actually comes down when you're using non-invasive ventilation. So there are 3 fields, if you look at this. There are 3 fields 30 years ago that they said which stood the test of time till now. The first field was continuous positive ambient pressure for severe cardiogenic pulmonary edema. That was the first thing. Till now, 30 years ago what was said is said now also that if you have cardiogenic pulmonary edema, the treatment of choice would be CPAP. That has been clearly proven 30 years ago and still holding this. The second place where you're going to use it is chronic obstructive lung disease. So that's another one. Chronic obstructive lung disease. That's also stood the test of time. Now also if somebody asks you what is the indication for NIV, you can put it clearly saying that cardiogenic pulmonary edema is my first indication and my second indication is going to be chronic obstructive pulmonary disease. That is my second indication. Whereas the third indication is now kind of not very great but now coming up in a big way after the advent of COVID, which is acute respiratory failure. So 3 things that were talked about 30 years ago has now also stood the test of time. So when you are going to give your exams or for that matter talk to anyone about the importance of NIV, there are 3 diseases in which you can be certain. One disease is cardiogenic pulmonary edema, The second is chronic obstructive pulmonary disease. And the third thing would be acute respiratory failure. You can be kind of certain that these are the things where I will probably use this. You can't talk it in anything else. You can't say pneumonia. You can't say I'm going to use it for neuromuscular junction problems. You can't say, those are all suspect indications. So the three indications are what all? Clear cut? Cardiogenic pulmonary edema,
COPD, acute respiratory failure.
Acute respiratory failure. There are three important places where you'd like to use your this. So when I was making this talk, I actually put NIV and outcomes to see whether it really changes outcomes. And look at the number of results I got. 1,868 results. I got 1,868 results, indicating the fact that it is a well-studied topic. It's not a topic that has just come out like that only. It's a well-studied topic. And in fact, when I put Cochrane, what is Cochrane? Cochrane is a repository where they do a lot of trials together and they try to figure out some kind of answers to certain pertinent questions. The Cochrane is what? Cochrane is a database where what happens is that they take studies, a lot of these studies together, they analyze it and they give you some plain language conclusion saying that this is probably what it is. So when they looked at that, there also if you see right from 2017 to 2022, they have done these particular reviews that non-invasive ventilation for people with respiratory failure to exacerbation of COPD is kind of improved. It has improved in patients, it has helped in acute respiratory failure in some neuromuscular junction disorders. Okay, so it's an observational study that it should be trialed. It should be trialed in such patients who have neuromuscular junction problem. For example, myasthenia gravis. For example, GBS. You can trial it in these patients because invasive ventilation seems to be more disastrous as compared to this. In those patients who don't have bulbar weakness, that is okay. The other one is a breathing intervention for shortness of breath due to heart failure. We know that cardiogenic pulmonary edema. It is a great intervention. Also, it improves mortality outcomes. It's something that improves mortality. High flow nasal cannula for patients with adult intensive care patients. This is what we saw in COVID, isn't it? The whole world started using this. This machine has become important really after COVID. We were using it for a while before this. But then this machine became very big during COVID. I know when you worked in COVID, this was something that was used right, left, center, isn't it? HFNC. Non-invasive ventilator at night for patients with COPD. Patients who have obstructive sleep apnea and COPD, non-invasive ventilation at night. Okay, non-invasive patient with central sleep apnea. So these are the cases which have also been studied and they have a lot of evidence when it comes to that. But it can be an extremely dangerous tool. Extremely dangerous because there are a few rights that you need to do. You need to have the right indication. So as now you know the right indications for this. You need to have the right route. The right route. Okay, it has to be the right route. Whether it is nose, whether it is oral, whether it is oronasal, whether it is face complete, whether it is helmet. What is the interface? That is called as interfaces. Which is the interface I'm going to use? Is am I going to use oronasal? Am I going to use nasal? Am I going to use helmet? What am I going to use? It's very important. What is the time at which I'm going to use it? Am I going to use it now? I'm going to use it after some time. Where is the time I'm going to try using it? At what time? And for that matter, how long? If I'm going to use it, how long am I going to use it? Okay, that's very, very important. So the other thing is, what are the physical characteristics that will help us to know that this patient will do well with an HFNC or for that matter an NIV? Then settings, where will I use this? Setting, in what setting? Will I use it at a home setting? Will I use it at a house setting? Will I use it at a ward setting? Will I use it in an ICU setting? Where do I use this? And other thing is, how do I monitor this? So you have to know many things when it comes to using a non-invasive ventilation. Many things. It's not so simple that we think that just laga ke chhod do. It is not like that. If you think it is like that, then medicine has got nothing to do with you. You should leave medicine and go. Because everything has got a right thing, a right place, a right setting, a right interface. Everything has got medicine. Right? And one of the most important things you must understand is, I will not use it when there is multi-organ failure or if there is an unmonitored environment. I will never do this. I will never in my life do this. I will never use it in multi-organ failure because it is going to fail only. That machine is going to fail. The NIV is going to fail. That is why the moment I develop multi-organ failure, what do? I would invasively ventilate. What did I do for that patient?
Invasive ventilation.
Why? Because he has
multi-organ failure.
He's got 2 organs that's failed. Right?
Okay.
Till yesterday it was 1 organ. I was like, okay, we'll try HFNC. But then of course there were certain things that you needed to look. I'll explain to you what. Okay, multi-organ failure and unmonitored environment, I will never use it. Right? So the entire point is, why intubate in the first place? The first question is, why do you intubate these patients? You want to use HFNC and NIV. The first reason to intubate is CO2. The first reason to intubate is CO2. If you have a carbon dioxide that is rising up, you can't take that carbon dioxide out unless you ventilate your patient. So intubation is required for CO2 retention. You can't blow off carbon dioxide in IV. You can't go ahead and use an NIV to blow off carbon dioxide. It's not going to work like that. It's not going to work like that. Clear on this? Tomorrow, if you think that the PCO2 is elevated, let me use an NIV and the patient will get better. No, it's not going to get better that way. It's not going to get better that way. So, because the more you wait with the CO2 that is elevated, the more the patient will get obtunded, and the more the patient gets obtunded, the patient will aspirate and die. You understand?
So level flow,
Huh.
data coding,
Huh.
the CO2 was increasing again and again. So we should.
That's what
maybe
reduced
we
to,
should take away. But before that also intubation was the first thing.
Key, first key. No, that's it. You didn't survive, right? You have to put the patient on the ventilator. Okay, there are certain places where we would use that, but that is not the point that we're trying to prove here. There are many things that we can do, but on an average, if the patient has got high CO2, you can't blow off carbon dioxide using NIV. You might think like this, that if I put NIV, I'll wash out the carbon dioxide. It never occurs that way. It never occurs that way. You are understanding? So you can't use the NIV to blow off carbon dioxide. So it's a wrong thing if you say I'm going to do I've seen the PCO2 to be 70. Let me put an NIV, and if the PCO2 improves, patient is doing well. Patient is doing well not because of an NIV. Patient is rather doing well because of your Deolin, because of your Budecort, because of your steroid, because of the way she is. He's not doing well because of NIV. समझ में आ रहा है? NIV is only supporting. So there is no point of targeting your NIV based on carbon dioxide. Clear on this? So that is why it is wrong to keep repeating blood gases again and again to see what is happening to my CO2, and then I'm adjusting my NIV. No, I may want to do it just for the sake of it, to understand whether my sedation is causing carbon dioxide retention. I may want to do the ABG just to understand whether metabolic acidosis is developing, but I'm not going to do ABG to set my NIV. That is wrong. So are you understanding what I'm saying? So one of the reasons I want to invasively ventilate my patient is because CO2 I want to remove. What is the other reason I want to intubate these patients? The other reason I want to intubate this patient is because there is hypoxia. Right? If there is hypoxia not relieving with NIV and HFNC or whatever oxygen devices you are using, oxymizer or whatever you want to use, and the patient is hypoxic, there is nothing you can do. You have to intubate your patient. There is nothing you can do. You have to intubate your patient. So there are two reasons why you would intubate your patient. One is carbon dioxide. Second is hypoxia. So that's why your thinking should be very clear why I want to intubate these patients. And the third reason why you want to intubate your patient is tiredness, isn't it? At the end of the day, everyone will get fatigued. Carbon dioxide, oxygen, whatever happens, the end result of all of this is fatigue. Okay, the end result is fatigue, and you can't have a fatigued out patient and you're putting any kind of other device. You need to intubate them. Fatigue is very, very important. That fatigue doesn't require you to do a blood gas. It doesn't require you to do any kind of major investigation. You just have to look at it. Okay, if he's getting fatigued out, there is no point of continuing your NIV, HFNC or whatever it is. That patient requires to be intubated. So there are three reasons. What are the three reasons? Carbon dioxide, oxygen and fatigue. There are three reasons why you want to intubate your patients invasively. Right? So what does NIV try to do? Now think what NIV tries to do now. Till now you thought intubation. NIV tries to ventilate your patient. It tries its level best to ventilate your patient. The second thing it does is it tries to oxygenate your patient. The third thing it tries is airway protection. You can do this only if the patient remains less hypoxic or less obtunded, that the airway will be protected. So by trying to get the patient better with ventilation, by trying to get the oxygenation better, it tries to protect the airway. Okay, tries to protect the airway, but importantly, the patient should have a road to improvement. So you can't put an NIV to a person who's not going to have any improvement. The thinking should be, okay, the trajectory is such that this patient is improving. So I need to monitor my trajectory. I need to monitor where I am. Okay, I can't just put the NIV and think this is going to be my treatment. If my NIV I have put and my trajectory is not good, this patient is not going to do well. I need to invasively ventilate. That's why the trajectory becomes very important, and that is the reason we should be able to understand what to monitor. If you do not know what to monitor, your trajectory will not be good, and you will not understand your trajectory is good or bad, and this patient will flop and die. And that is the reason you need to monitor, but the question is how? So the most important thing you need to monitor is your basic saturation. Basic, absolute simple thing, saturation. Simplest thing that you can do on monitoring is saturation. You don't need a blood gas. You just need to look at the saturation. You just need to, you don't need blood gas for this. Just look at the SpO2. To give you an example, tomorrow if you have a blood gas and your blood gas shows 55 PO2, the saturation is 91. Now looking at ABG 55 PO2, you're scared. 55 hai. लेकिन मेरा saturation तो 90 है. You're not scared. It's 90. You understand? That's why that ABG gives you a false sense of danger. First of all. You understand? And who wants to put an artistic for a patient who is so painful it is? You don't want to do that because it's not going to add on to anything. I have my saturation, that is enough for me. I don't need anything more than that. My saturation is maintained, everything is maintained. Are you understanding this? So the first thing I want to figure out is saturation. I need to have a saturation probe in place. If I don't have a saturation probe in place, I am not doing the right job when I'm on NIV. Any kind of NIV or HFNC. Right? I need to have the SpO2 in place. Without that SpO2, it is a very wrong and criminal to take care of these patients. You should have the SpO2 on all the time. The second very important factor is mentation. Okay. So you have a patient who basically comes to you with breathlessness, and you put the patient is tripoding. Tripoding means you're holding. The patient is tripoding. For example, he's sitting like that, breathing like that. He's agitated. He's restless, or he's obtunded. One of the two things. He's one of those things. That means his mentation is worsening. You understand? Mentation is worsening. If the mentation is worsening, this is not the patient that will be carried out with HFNC or NIV. Clear on this? Mentation, very, very important. So the question that you will go and ask the relative is, are you okay? Patient is, ठीक लग रहा है क्या हो रहा है? आप ठीक? He's getting more restless, he's getting more agitated, he's getting more obtunded. This is not the patient. The trajectory is wrong there. The trajectory is wrong. You put on HFNC, you put on NIV, patient is worsening. So ideally what you should have it written in your paper. 20 minutes later, I've seen this patient is looking better, already feeling better. I'm not looking at that time at a blood gas. I'm not looking at a PCO2. I'm not looking at a EPaO2. All I'm looking at is the mentation. How is the patient mentating? And another very important part is respiratory rate. If there is one metric number that you have to choose, if there is one number you have to choose in the monitoring of NIV, it is respiratory rate. If there is one number, अगर भगवान ने बोला देखो एक ही number देखना है, वो एक number कौन सा रहेगा? Respiratory rate. You understand? One of the most important numbers that you have to look at when it comes to monitoring patients with non-invasive ventilation is the respiratory rate. So the moment you put the patient in HFNC and NIV and then you say that the respiratory rate has dropped by 5, 10 or 6, means your trajectory is good. It means your trajectory because saturation is not going to move that much. These patients are going to be grossly hypoxic, वो 90 करेगा. Mentation will also be not certain, but you will see the RR, you will see the number coming down. Okay, that's one number. If you have to think, I think the most important number that we can think of in such cases is respiratory rate. One of the best metric that you have in these cases. Now, oral roca long ago, not long ago, COVID times, no, we were all using HFNC very regularly. You know how it was being used abroad? HFNC was used in everywhere. It was used in the ward, used in some other place, used in the casualty, used in every other place, and used by people who are ophthalmologists, used by people who are orthopedic surgeons, people who don't do with intensive care, ward doctors. You know, that is what people were using. So at that time it was very difficult to make people understand this. कि क्या है इससे क्या करना है क्या देखना है क्या मॉनिटर करना है patients were dying ICU cases there were too many patients in the intensive care unit there were less beds in the intensive care unit how do you monitor them and that is why Oriel Roca at that time came up with a beautiful index and that index is called as a ROX index. So if the patient is going to be on HFNC you need to monitor the ROX index which is nothing but respiratory rate and oxygenation index. What did we say? What we're going to monitor? RR and saturation, right? This is exactly what we're going to monitor, right? So this index is so beautiful because if you look at what it contains SpO2, which we are monitoring, it contains FiO2, which we are delivering, and it contains RR. All three being non-laboratory parameters. All three being non-laboratory parameters. You don't need a single investigation to find the ROX index. You just require what you're seeing SpO2, you just require respiratory and you require FiO2. This is what it says. And importantly, what does it say? If it is more than 4.8, it is good. That means this patient is going to do well, first of all. Right? Got the point? Yeah. But when I did start the lecture, what did I tell you? You should see the trajectory. You should see the trajectory. Okay, so I want to see the trajectory. So how do I find the trajectory? That is why when you put the patient HFNC or NIV, you should have these three time points: 2 hours, 6 hours and 12 hours. You should have these 3 time points. So whenever you are monitoring your patients with HFNC or NIV, you should have 3 time points, 2 hours, 6 hours and 12 hours. So at 2 hours the note should be there, 6 hours the note should be there, 12 hours the note should be there. Indicating, because NIV is not the solution, NIV is a support. How long to give the support is very important. So NIV is 2 hours, 6 hours and 12 hours. How do I do this? As I told you, the first thing is any of these times, if it is more than 4.88, that ROX index is more than 4.88 means I am doing well. This is a good patient. He will probably have successful HFNC or NIV use, and he will not go into an intubation condition. He will not go into this. Right? Now at these time points, you are supposed to see like this. If it is less than 2.85 at 2 hours, no, don't wait. Intubate this patient. Just tube this patient. If it is less than 2.85, just intubate. Don't wait. Okay, just intubate this patient. 2.8. Simple score. It's not difficult. Very simple. You just have to remember some numbers. 285, just intubate. At 4 hours, the score slightly changes. 3.47 at 4 hours. And at 12 hours, it changes further to 3.85. Right? So these are the scores that you look at 2 hours, 6 hours, and at 12 hours. Clear? Anything in the middle, let it be anything in the middle, what am I going to do? I am going to do some adjustments on my machine or on my therapy to ensure that this changes by more than 0.5. This number changes by 0.5. Anything in the middle. So I don't need to remember these things, but anything in the middle. Okay, what am I going to do? I am going to do some changes in the way I ventilate my patient by NIV or the monitoring or the way I am going to change my gas flows in order to ensure that the score changes by 0.5. Clear? If the score changes by 0.5 means I am still doing well. Clear on this? Have you understood the ROX index?
Yes.
So it's simple. So next time you put the patient on HFNC or an NIV, what do you need to do? Calculate the ROX immediately, which is not difficult to do. It's not difficult at all. Immediately you get it. At 2 hours you'll repeat it. At 6 hours you'll repeat it. At 12 hours you'll repeat it. Apply the formula. And say for example you were at 2 hours it was less than 2 point, it was 2.9. It was 2.9. It is definitely not more than 4.8. It's at 2.9. I need to do something to my patient or my machine to ensure that this changes by 0.5. You understand? Understood the point? So this is something that you have to understand. And what do I do? What do I do to change that? What is the thing that I need to do to change this? That is what you're going to understand now. So for that you need to understand certain things about HFNC. Okay, so in HFNC, they did this beautiful study. Thomas Maury is a very big man. He is a fantastic young individual who really went to the spotlight once that COVID came inside. Oriel Roca and Thomas Maury, two people, they went into huge spotlight because of the fact that when COVID came in, they were the ones who did most of the investigations to let us know what to do with these kind of patients. Okay, so he was already doing HFNC. He was one of the pioneers of HFNC, working a lot about HFNC. So he did this study saying, how do you optimize HFNCs? And how did he do that? He looked at patients, looked at the ABG, looked at the effort, and looked at lung volume by EIT. This is what he did. So what he found when he was doing this investigations is that once you increase the flow, it does a few things. When you increase the flow in the machine, it reduces the change in pulmonary transpiratory pressure. That means to say, what is happening in patients who are breathing on their own? When they're doing this, what is happening? There is going to be self-inflicted lung injury. It's called patient self-inflicted lung injury, which is also called as PCL. At that time, this term was not there. This term came in after COVID. This is 2017. But what we know is that the patient self-inflicted lung injury is something that occurs when you are in negative pressure ventilation. When you are in positive pressure ventilation, it is barotrauma. It is different. But when you are in negative pressure ventilation, you have patient self-inflicted lung injury which occurs because the patient is breathing excessively. So what it does intelligently while increasing the flow, it actually reduces the pressure of the transpulmonary pressure that occurs in negative pressure ventilation. At the end of the day, the distending pressure of your lung is transpulmonary pressure. That is your distending pressure. The distending pressure in your lung is transpulmonary pressure, right? So it is not your plateau pressure, it is not your peak pressure, it is not any other pressure, it is your transpulmonary pressure. When the patient is getting barotrauma, it is your transpulmonary pressure that is increasing. So you might wonder, negative pressure there should be no problem. उसमें तो negative pressure भी increase नहीं होने वाला है, बराबर negative pressure में. But what is happening in negative pressure is that transpulmonary pressure becomes negative. and that's why patient self-inflicted lung injury. So what it does, it actually reduces his PTP. What is a PTP? PES means he actually put esophageal catheters, found their pressures, and then accordingly reduced the PTP. It reduced the PTP. It reduced the transpumping pressure. So increase in flow, reduce the transpumping pressure, making it such that the patient was not getting self-inflicted lung injury. The second thing what happened to the increase in flow is it improved the end expiratory lung volume. So how did they do that? They did that by actually doing nitrogen washout, and they did it by doing EIT. So electrical impedance tomography for all those who worked in COVID here. Remember how it looked like? Who's there? You were there. No? You saw how the air was expanding and coming. When we use EIT, we used for 3 years, isn't it? So EIT, the lung expanding. So it actually improved the electrical impedance tomography feature, saying that volume was increasing, and because of that, the oxygenation went up. Because of that, the oxygenation went up, and it decreased the minute ventilation. It decreased the minute ventilation of this patient. So this happened with an increase in flow. So now you know there is something that you can do to actually optimize patients. You just now said that we want to move the rocks by 0.5. So there is something you can do. What you can do, you can actually increase flow. This is something you can do. Clear? Okay. So what will be the practical protocol here? So what is the practical protocol? Here, let's go one by one. So once you are going to put a patient on HFNC, what you should understand is, am I dealing with an oxygen problem or am I dealing with a CO2 problem? This is the first thing. What you must find out, whether I'm dealing with a O2 problem or a CO2 problem. This is very important. So in your mind you should think, okay, here is my hypoxia, there it is carbon dioxide. I must think like that before I'm putting HFNC. Okay, now see, when it is hypoxic, then what am I going to look at? This is my starting setting. So in the HFNC there are 3 settings I need to do. In this HFNC there are 3 settings I need to do. One is the flow, other is the temperature, and third is the FIO. All the HFNC machines will have 3 buttons that you need to look at. One is flow, second is temperature, and third is oxygen. There are 3 things that you're going to look at. So if I'm doing it with a hypoxic patient, I will start with the maximum flows, 60 liters. Because just now I explained to you that if the flows are high, if the oxygenation kind of improves. I explained that to you. And why do you think the oxygenation is improving compared to nasal prongs?
Delivery of your O2.
Sorry?
The delivery of oxygen at 100% is good.
So
it's less 60%.
Why is it less? You're right. Why is it less? So with the nasal prong you can achieve how much?
20.
No, every liter high you increase by 4%.
Yes.
So if it's 21, you reach 24, 28, 32, and 36 max. Because beyond that, we will have other problems. But how does this deliver 100%? That is delivering to 40%. How does this deliver?
High flow will increase the reservoir in
Where?
upper
Nasopharynx.
yes.
How does it do that? How does it do that? How does it increase? How does nasal prongs work? The question that comes is there now. How does nasal prong work? How does nasal prong work? How does, you are giving from the wall mount, you are giving 100% only. How does it become 20% here?
And it will lose while delivering. It doesn't go directly.
It's going directly only.
Mixes with the atoms.
Yeah, how? You're right. How does it do that?
While
No, no,
patient
no.
is breathing, it mixes with the air and that is a dilution.
Blue air. So you have a nasal prong, right? You are putting a nasal prong here. You are giving liters. You are giving 10 liters. You are giving 20 liters. 6 liters you are giving. Imagine in that small tubing there is 6 liters. Pen hai kya? Idhar kya pen hai? 6 liters, 2 liters, 4 liters. The amount of tubing is so small. Imagine you are putting 1 liter of Pepsi into that. It's not possible only, no? It's not possible. That's the amount of air that is going inside. A liter per minute. Right? So what happens is the tubing develops a very high pressure. The tubing develops a very high pressure. And the moment the tubing reaches the nasal nares, the low pressure develops over here. Now, low pressure, we know air will move from high pressure area to low pressure area. So the air from external source gets inside here. The air from external source gets inside here, resulting in dilution of the nasal prongs, and that is why the FiO2, though is coming from the flow meter is 100%, keeps on diluting as you increase the flows there. समझ में आ रहा है? Keeps on diluting. समझ में आ रहा है? So if I increase the flows here from 2 liters to 3 liters, Okay, it will further increase, but also increasing the liters also. So that way the dilution factor comes in place, which actually causes the nasal prongs to actually give you those separate FiO2s that we're talking about. And that is also the reason that when you're looking at nasal prongs, you don't want these patients to be breathing fast. If the patient is breathing fast, what is going to happen with nasal prongs? There's going to be more dilution. If there will be more dilution, you might want to deliver an FiO2 of 30, you'll be delivering not even 20. 21, 22 will be developing, air will be developing. That's why nasal prong is not supposed to be used in intensive care unit unless the patient is extremely comfortable at a RR of 12 to 16. RR goes more than 16, this is not the device. You got the point? Nasal prongs. But what happens differently HFNC? What happens differently HFNC? If you look at the prongs, the prongs itself are quite big. The prongs itself are quite big. Since the prongs are quite big and the flow is very high, there is no space for this to come inside, air to come inside. That's why the size of the nasal prong becomes very, very important. The size of the nasal prong. The orientation of the nasal prong. If you see the orientation is like this. Orientation is like this, which prevents air from getting diluted. That is why the size of the prongs makes a very big difference when it comes to hypoxia. And that's the reason I don't want little bit dilution also. That is why I will use the. You got the point? But whatever I'm going to start, so now we've understood the difference of HFNC and nasal prong, at least on the flow, at least on the physics. Now you monitor the RR, as I told you. Comfort, SpO2 rocks at 261 and mentation. Exactly this is what I said. Now what do you think would be the difference in carbon dioxide if there's CO2? Is there going to be any difference in CO2? If I'm going to use CO2 for the other side, initiation, will there be any difference?
FiO2 is lower, FiO2 should be
Correct. The FiO2 will be the COPD FiO2. I would not want to give FiO2 to 100%. I want to make it such that the saturation is 88 or 92. That is first thing. Then there are 4 things that we need to look at now.
Flows also, we can decrease the flows also, because we don't need to increase flow to. Well, the dilution is not the big issue.
Exactly.
Right now.
So I don't want to give high flows. Right? I don't want to give high flows. That makes sense. Oxygenation is not my issue. Right then. Canada?
Small.
The cannula will be small bore cannula. Okay, so the cannula will be small bore cannula. Because why? I want to ventilate my patient. This is not oxygenation now anymore. I want that he's ventilated well. So when you look at this is the data that actually talks about cannula size. Okay, now if you see the flows here, these are the flows over here, and this is pressure at the end of expiration on this side. The leak area makes a big difference on the removal of carbon dioxide. It makes a big area on the removal of carbon dioxide. So smaller the cannula, more the removal of carbon dioxide. Okay, clear on this? Smaller the cannula, more the removal of carbon dioxide. Got the point? So if I have only one nasal prong, I may remove one to ensure that there is more carbon dioxide removal. So am I right? It's very important to have the right cannula size for these patients. So in short, there are 3 sizes that we have in HFNC: small, medium, and large. Looking at the nasal prongs, looking at what my condition is, I will decide which to use. You can't just use the same for everyone, it doesn't make sense. Which you are doing now. Okay, you should be getting the cannula that is appropriate sized. Appropriate sized cannula we require. Clear on this? The size depends on nostril and the pathology. On the nostril and the pathology, right? Right. Now what about comfort? Okay, how do you take care of comfort? I said we want to monitor a few things, right? So I'm going to monitor my RR and change my flows accordingly. If I want to improve my comfort, the way you can improve comfort is by a combination of flow and humidification. Now flow also improves comfort. If the patient is not comfortable, you will realize that flow also makes a lot of difference. For example, look here, facial mask, HFNC 45, HFNC 60. Look at what happens to minute ventilation. It keeps on going lower and lower and lower as the flows increase. Means patient is getting more comfortable, otherwise this would not have come down. You understand? Minute ventilation is actually coming down. You see this minute ventilation? Minute ventilation is actually coming down over here. You see this? It's coming down. The end expiratory lung volume is going up as the flows are going from 30 to 45 to 60. Okay, the respiratory lung volume is going up very clearly. If you look at it in a picture like this, also this is EIT data. Okay, you see the volume is actually gone higher and higher. The volume in the lung has gone higher and higher, and you're clearly seeing that what is happening is that your respiratory rate is actually coming down, coming down, coming down, coming down. You see this? Respiratory is coming down. Airway pressures are slightly going up when you increase the flows, and at the same time, your end expiratory lung volume is going higher. This is what you're seeing. So very clearly, there is clear demonstration that lung dysfunction will kind of get better in all these things. So putting all these things together, if you look at HFNC and breathing frequency, there is a definite, in all the studies you put together, there is a drop in the male ventilation, which is basically related to comfort. When we put all these 44 studies together, we find the same thing. All 44 we put together, we find the same thing. We find that the work of breathing actually is coming down. This is the work of breathing is actually coming down. Okay, so there is a clear improvement when it comes to that. And importantly, when I look at comfort, the other important thing is the temperature. So how do you monitor the temperature? The temperature is also based on comfort. So what happens over here? Very clearly, on the x-axis you are having temperature, flow and temperature, flow and temperature, flow and temperature. Now we are not concerned with this group. This group is a patient whose FiO2 is very low. We are concerned with the patient's FiO2 in the higher group. So here is the group where the FiO2 is more than 45%. In those patients who require higher FiO2s, when you actually increase the flow as well as the temperature, the patient gets more comfortable. This is what it is. So as you increase the temperature, the patient gets more and more comfortable along with the flows. So if you want to improve comfort, I need the temperatures to go up, I need the flows to go up. Right? So in a COPD patient is not comfortable, I increase the flows a little bit, I increase the temperature a little bit, so that it gets kind of better. That's why you must understand this, okay? Next is oxygenation. So we know that higher the flows, higher the oxygenation. We just discussed that if you go up on the flows, the oxygenation will kind of get better and better. Very clear. Whereas in COPD, what do? You want to maintain it at, as per the SpO2 that is required, 88 to 92. Okay, so you will take care of the flows in that way. So now, have you understood how to monitor HFNC and how to use HFNC? You understood how to use HFNC? समझ में आया? Any queries till now on HFNC? Till now? Okay, so when you look at the HFNC device, it's got a flow meter that is very different from the other devices. The flow meter is calibrated at 10 liters, 10, 20, 30, 40. You can't use this flow meter or the wall mount flow meter with this machine. You can't use it because you require flows that are reaching 60 liters a minute. So the next question that comes is, let's now look at non-invasive ventilation when it comes to these similar situations. So we'll just look at non-invasive ventilation, okay? Alright.
Flow meters of flow.
Flow meter, okay. So the flow meters, so there is only these kind of, you cannot use these flow meters, you cannot use the ones that are there on the bed side. The bed side is at 15 meters, 60 max, okay? You don't have more than that, so you can't use those flow meters over here. So when you, HFNCs, now this is not the, HFNC can be in different ways. You can have the ventilator having HFNC. Are you understanding? You can have the ventilator, for example the Evita XL has got HFNC. The difference is going to be the circuit. Right, the difference, how this is working, this has got a machine here, okay, which has got at the end of, from back side it takes in the air, it takes the air from back side, and it has got oxygen that comes from here. There's a machine inside called as the blender, okay, the blender takes this oxygen, takes the air from outside, blends it and gives you the FiO2 that you're asking for. You're asking for 40 blends, that it asks for 50 blends, that it gives it to you. Right, and that's how this works. And since you're giving this oxygen in a very high amount, these flows are very high, you need to humidify them. Others it will be very high. Has anyone worn a nasal prongs at home or at the hospital environment anytime? If you wear it, you realize that you don't want this thing in your life. No, it pains, it stings you. It stings you. After 3 hours or 4 hours, it starts stinging you. So I was on nasal prongs by HFNC for a while. It was very bad. The nasal prongs were very, very bad. So it was I could not tolerate for more than 5 hours. After 5 hours, I said, you give me an NIV rather. It becomes so difficult for me. Because it was full, it stings you because it's very cold. Very, very cold. See, it's better the plant there. It comes from a plant over there. The plant is giving freezed oxygen, From freezed oxygen it is coming up and liquid oxygen and then it comes to you. Very cold, very, very cold. It stings you. Okay. So obviously you can't use that because you're giving now 60 liters and 70 liters of flow going from here. Right? So it needs to be humidified. So to humidify, we have a device that is placed inside this. Can you get one humidifier? So in humidification, you have to place something that is kept over here. Okay, so that humidification attaches over here and then this tubing attaches over here. So if you have a ventilator that has got HFNC, if the ventilator has got hypernasal cannula, the ventilator will have a separate humidifier. You're understanding? So there are ventilators that have, our ventilators have HFNC. Our Evita XL has got HFNC. But if you want to use that, you need a separate humidifier. You understand? You need a separate, here there is a humidifier attached here. Clear on this? Clear on this till now? Clear on this now? And on these there are very few buttons. It's a very simple device to use. Very few buttons. You first switch it on. Switch it on. Okay, you first switch the machine on. Okay, and no machine should be lying like this, like how this machine is lying. I mean, this is for you. Okay, you cannot have a machine lying like this. Okay, the machine when it is not in use, it should be attached to a red tubing. Okay, Amrit, it cannot be kept like this. The machine. No machine should be lying like this. If there is an HFNC that is lying somewhere, it has to be attached with a red tubing, which actually indicates sterility. No, don't take it out. Take it out. Okay, so where can you get the red tubing, please? So if there is a machine lying anywhere in the hospital in the ICU, the machine should be attached to a red tubing. Why is that so? Because between patients it needs to be sterilized, and the indication that this is sterilized is the red tubing here. Once they attach the red tubing over here, okay, it means it is stabilized. It is sterilized. ऐसा नहीं होना चाहिए machine कोई भी. It should not be. It is kept beside, not being used. It cannot be kept like this. It has to be sterilized. Sterilization cycle is an hour. You just have to attach it. It starts sterilizing on its own. So this machine, if you are going to take it from somewhere, it has to be attached like this and kept. Then you take this out and then you start using it. समझ में आ रहा है? It cannot be used without sterilizing this machine. Clear? So what we are using over here is a humidifier. This is the humidifier. Can you see? This is the humidifier. Okay, the humidifier has got water that comes in. Sterile water can't use normal saline. If you use normal saline, it will crystallize. You have to use sterile water. So it's written sterile water over here. It's the sterile water that will attach to this, and this sterile water gets into this. When you buy this machine, you may have some different kinds, but in this one, you see, this is how it is. So what happens over here is this will go inside this. इसका cap किधर गया? This is the cap. This is for nebulization by any chance. So I'll close this over here. How does this go inside? How does this go inside is? Okay, it has to be pressed from here. It has to be pressed from here, and then it has to go inside, right? See, it goes inside, and then it has to click. Now it's clicked. So this is how it gets clicked. Once it gets clicked, you attach it over this place, and then you attach this tubing. This tubing is a single tubing, okay, which has got a small apparatus at the end. This will go inside this. Can you attach it? Can you attach it? One of your. No. So anyone wants to try it out? So look at it and attach it. Look at it and attach it. It will spoil it if you attach it anyhow. Click. You saw that click? That's how you attach it. You cannot attach it. Zoom it out. Okay. So you have to press it. So you have this over here. These points should match the points over here. It should match it over here. When you remove it, you have to press both the sides and remove it out. You have to press both the sides and remove it out. This is how you attach the HFNC. Clear? And then this goes inside the nasal cavity. And this, and then there is this one. This has got a huge drag. If you hold it, there's a drag on the circuit. There's a huge drag on the circuit. So you can't have it just lying like that. It will displace. If it displaces, the nasal prong moves slightly here and there. Again, dilution will start. Right? And that is why they provided this thing. This is so that it gets attached to the shirt over here. So that this gets attached to the shirt over here. If you don't put this, it will drag. Once it drags, it will move. If it moves, what is going to happen? Dilution. It will not give the right amount. Clear? So when you switch this on, there are only three attach this on this. There would be. Can you switch this on? When you switch it on, there are what opens up over here is air VO2. It says there are many such devices. Okay, it says air VO2 here. Okay, and every device has got a different operational, but the numbers will remain the same only. What are you going to? So 1 day 24 hours. So you understand this is not checked. Whatever. So you can adjust the flow. Okay, how do you adjust? When you press both of them together, it unlocks the whole thing. it unlocks the whole thing. When you press both of them together, it unlocks it. So you can apply. So if you, so she's put it now. So once she puts it down, it just goes round, round, round. It just goes round over here. Okay. What it shows, it has shown three things. It shown what is going on now. It is showing the temperature, it is showing the liters, and it is showing the FiO2. If I want to change anything, I need to press both of them together. Okay, or press this like this, so it opens up this 34. If I want to change this, I unlock it. I unlocked it. Once I unlock it, then I can increase or decrease. If you just not talk about, right? And then I leave it, it becomes like that again. Clear? If I want to change the flows, again the same procedure. Press this tight, unlock. Every machine will have a different way. This machine is like this. If I want to increase the FiO2, what do I do though? If I want to increase the FiO2, there is no log, there is no FiO2 change. You see, there is nothing. There is the temperature and this FiO2. How do I change this? By increasing the flows here. There is no button to change this. I have to change the flow here and see what's happening here. Someone I have to change the flow and see what's happening here. That's what you do. Okay? Clear? Box index at 2, 6 and 12. You're going to make the alterations here. To understand whether this patient is doing well or not. Clear? Now let's go to NIV. Okay. So you have pressure. Let's just very basic about NIV. Okay. You have pressure on the y-axis, and you have time on the x-axis. Okay. Now what I'm going to show you now is basically normal breathing. This is normal breathing. When you're breathing normally, your inspiring pressure is going up, expiring pressure is going down, but not going to zero. Inspiring and expiring, inspiring and expiring. This is what is occurring when you're normally breathing. Okay. What happens when you start breathing? When you start CPAP, when you start set positive pressure, there is positive pressure at inspiration and there is positive pressure at expiration at both the sides. That means to say at inspiration or at expiration, there would be a positive pressure. So I am giving a positive pressure, say of 5. If I give a positive pressure of 5, what is going to be my graph? The graph is going to be like this. This is CPAP. That means to say, since I have a positive pressure, my pressure has gone up here. That is my end expiratory pressure, which I can also call as PEEP. It's also gone up. But at the same time, what has also gone up? My pressure over here, my peak pressure, that has also gone up. This is called as CPAP. When I say CPAP on non-invasive ventilation, it is called as CPAP. When I do it on invasive ventilation, it is called as PEEP. Positive end expiratory pressure. Positive pressure on invasive ventilation is called PEEP, and otherwise it is called as CPAP. It means the same. So when next time when Dr. Sachin shows the various ventilators, you have to identify what is CPAP on this, what is GeoPAP on something else, or what is NIV on something, what is FONT on another one. They all mean the same. The taxonomy is different, but they all have the same physiology. They're doing the same things. You should understand what is what. That's why you have to understand the concept. Like just now, we had a patient on the ventilator. We didn't know what kind of. I want to put the patient on pressure control, but you're not searching for. There's no PC written anywhere. You should understand what is what. You understand? You should understand. Okay, this is that kind of mode of ventilation or whatever that is. Clear? This is called as CPAP. Any doubts on CPAP yet? Okay. Now, what is the other form? If I want to give the CPAP and add another pressure on it, which sometimes you call as pressure support over PEEP, or sometimes you may call it as IPAP, EPAP. You may call it whatever. There may be many pressures. You can say PS plus. There are many names for the same thing. So when I add another pressure on top of my EPAP, if I add another pressure on top of my PEEP, if I add another pressure on top of my EPAP, and I add say another pressure on top of it, that will become bi-level positive airway pressure. This is called as bi-level positive airway pressure. Okay, so what have I done over here? I have not only kept my CPAP in place, but I've also added a pressure above that, and that's why this is called as bi-level positive airway pressure. The pressure is at two levels. It is at the expiratory level and it is at the inspiratory level. Are you understanding?
Awesome.
Pressure support, we have EPAP and we have IPAP. You've understood this now?
Yes.
Ankit, have understood this? Kadapa, have understood this? Bi-level airway pressure. You can call it by various terminologies. People call it BiPAP, people call it biphasic, people call it different kinds, PS with P, people call it as NIV, people call it as various names. The taxonomy is very different. Okay, but you should understand the basis of it. So I'll repeat it again. Normal respiration is what you're seeing here. Inspiration, expiration, inspiration, expiration.
Yeah.
When I add a CPAP, a continuous positive airway pressure, the pressure just goes up, but this is so the tidal volume here is 500. Here the tidal volume also 500. If the person is breathing at 500 tidal volume, here also tidal volume is 500. Only that he is breathing like this. This is how he is breathing. You got the point? If I breathe like this, how I breathe normally. If I put a pressure to myself, I'm holding the breath inside. But I am having the same tidal volumes. When I go to bilevel means this is what's happening. You understand? I am having a increased pressure support on top of my. So what will happen to my tidal volume? Increase. My tidal volume will increase. So here my tidal volume remains the same. Here my tidal volume will increase. And my amount of pressure support that I gave will actually change my tidal volume accordingly. You understand? The amount of tidal volume क्या हो गया?
15 minutes.
Right? Sakib, go and get one NIV now quickly. Get an NIV with mask. Amrit, get an NIV. NIV with mask as well as tubing. Any doubts on bilevel positive airway pressure? No, right? So let's go to how this helps. So this CPAP will help in patients of, we started by talking cardiogenic pulmonary edema. Okay, so CPAP and bilevel PAP will work for patients of cardiogenic pulmonary edema. How does that do that? How does it do that? How does it do that?
It acts positive and expiratory pressure.
So what does that do?
That will remove the alveolar edema.
How? So there are a few reasons why this will work. Okay. So when you are actually putting, what have we understood? That the minute ventilation is coming down. What have we understood? When you are putting an NIV, when you are putting an HFNC, in the right person, what is happening? The minute ventilation is coming down. That means the patient also getting comfortable. That means the sympathetic response is coming down. Okay, if the sympathetic response is coming down, this works in such a way that it improves the heart. The heart is at a high sympathetic load when it's in failure. When it's in failure, the heart is in very high sympathetic load. It's like dying. That's why it's in failure. That's why it's called failure, isn't it? It's called heart failure because it's dying, isn't it? So it is, you are trying to make it alive. So when you're actually putting these patients on NIV or HFNC, what is happening? The patient's sympathetics are getting better. So when the sympathetics are getting better, what is also happening? The afterload of the heart is reducing. The afterload. What is the afterload? It is that pressure with which the heart is pushing against the compromised circulation, against the circulation that is compromised, that is constricted. So the afterload is coming down because the anxiety is coming down, because the sympathetics are coming down. That is one of the mechanisms. The second mechanism is physically it is altering the afterload. How is it doing that? Any cardiac afterload is equal to transpulmonary pressure divided by 2T upon R, where transcardiac pressure and radius, this is what it is. The formula is afterload is equal to transcardiac pressure, that is inside pressure minus outside pressure. In this case is inside pressure minus outside pressure upon radius of the heart. This is the definition of afterload. 2T upon R. What is the definition of afterload? 2T upon R. Inside pressure minus outside pressure. Clear on this? Okay. Radius of the heart I can't change. I can't change the radius of the heart in any way. What I can do, I can alter the outside pressure by increasing PEEP. The pressure outside the heart is the PEEP. Right? So if I increase the PEEP, the lungs get inflated and it kinds of outside pressure it comes in. So if I were to increase the outside pressure, this equation will decrease. That's why afterload comes down. You understand? So this means to say, if I have a patient of cardiogenic pulmonary edema, my therapy to reduce afterload would be to actually try to increase the pressure support as much as possible, increase the CPAP as much as possible, because as I increase my CPAP, my outside pressure goes on going higher and higher and higher, in effect dropping my Understood? So if I have a patient on LV failure, what are my settings going to be? If it's an LV failure, what are my settings? If it's an LV failure, Huh?
High.
I want to slowly increase my PEEP to the level that the patient is tolerating. To the level that the patient is tolerating. So this means I stand with the patient, I apply it, and then I go 2, I go 6, I go 8, I go 10. And I see how the patient is tolerating it. You will find out that the moment you reach a pressure of 8 or 7 or something around 6 or 8, there will be sudden change in the patient's overall condition. You will see the pulse rate getting better, you will get the RR getting better, you will see the patient getting less breathless, and that is what you have to observe. So when you're titrating your patients on NIV, so if I were to start the patient on NIV for cardiogenic pulmonary edema and I want to use CPAP, if I want to use CPAP, I will not increase my pressures to an extent that the afterload is coming down. Clear? And how do I know that the afterload is coming down? When the pulse rate is reducing. Because afterload hai isliye pulse rate fast hai. Pulse rate is reducing. What will also happen? Blood pressure improving. Sympathetics coming down. Pulse rate coming better. So many things are happening. RR is coming better. So that's how you titrate it for cardiac. Whereas the other side, this part of the story will work for both. Bi-level positive airway pressure will work for cardiac system as well as for respiratory system. Clear? Clear on this? Now let's go to the practical application of how to use this. Alright. So, very important. Very, yes please.
So, how do you decide whether you use
एक coffee in
CPAP versus bi-level? We can use both the modes in cardiac pulmonary edema. How do we decide for CPAP or bi-level?
Sorry?
You said we can use both, no? CPAP and BiPAP both.
Yes,
You use
yes,
pulmonary,
yes.
So you're cardiogenic. So
Yes.
how do we decide which one to use?
We'll come to that.
Yeah.
We'll just come to that. Okay. So her question is, what do I use, CPAP or BiPAP? When I use both, what do I use? That's the question, right? So we'll come to that. When we come to the practical application. We'll first come to the practical application to understand that. So as we understand the practical application, understand this question also. Okay. So first of all, when we are actually looking at practical application, you must understand what kind of interface I have to use. Last mechanical ventilation workshop, who all have attended? You have attended, right? None of your Niharika, you didn't attend? So what were the interfaces you saw? The last one.
NIV, Oro.
What are the interfaces? So when I talk, you must talk properly. What are the interfaces we talk about?
Oronasal mask.
So one is oronasal mask. Okay, oronasal mask is the one that will cover your mouth and your nose. Oronasal mask, the one that you're using here. Oronasal mask. That is called as oronasal mask. Then
Nasal mask, only covering the nose.
so nasal interface. So nasal interface. Nasal masks are various types. Nasal mask में क्या होगा? There is nasal mask like this. There is nasal prong like this. There are different kinds. Nasal cushions are there. Nasal pillows are there. So when you have not attended the workshop well. सो रहा था क्या workshop में? उसमें सब कुछ रखा हुआ था. बराबर ना? हाँ. So nasal cushions, nasal pillows, nasal mask, nasal prongs. These are the various nasal interfaces we have. See, when you're attending a workshop, no, keep your eyes and ears open. It's very important to attend this properly. Workshops, okay? They are giving you things on a platter. You don't need to read. It's on a platter for you. You just have to look. That's all. Okay. So nasal, because you always think I'll study later on. It doesn't make sense. You are all your life going to study only. So you might as well be attending the workshop study. Finish off. So nasal pillows, nasal cushions, nasal prongs, and nasal masks. So there are different kinds. All are different. So tomorrow when you see something, you say, what is this? This is nasal pillow. Oh, what is the nasal prong? What is the nasal cushion? They are all different kinds. Unless you see it, you will not understand what it is. But there are different interfaces when it comes to the nose. Okay. So the interfaces you can talk of is nasal. Okay. Then what did we talk about? You said nasal interface. Then oronasal. Then oral. There is oral interface. Oral interface is just you have a mask. You have a mask that is applied to the mouth, only to the mouth. Mask that is applied only to the mouth. Okay, the mask is not applied anywhere, it is applied only to the mouth. But the oral interface, okay, oral interface. Then what do you have? Oronasal we talked about. Then what is the interface you have? Helmet. Full face mask. So when you say full face mask means what? It is covering the whole face. We saw it last time in the workshop also. Full face mask. That is also an interface. Full face mask. And the other one is the helmet. So you as a doctor in the intensive care should understand what I should be using. Okay, I've got so many things. for NIV, as I told you, the right interface is very, very important when I look at NIV. Right interface, very, very important. Okay, so what will be the right interface in the ICU? What is your thinking? What will be the right interface? Kadapa? Why? You're right. Why? Anyone? He's got the right answer. Anyone? Why should it be the oronasal mask? Why do you think it should be oronasal mask? Any idea? Tell me one thing. If I tell Atul to run from here and run back and come back, how will he breathe? Exactly. So classically, when we are in stress, our breathing goes from nasal to oral. Classically, when we go from when we go to a stress response, we move from nasal to oral. So whenever a patient is in a stress response, his breathing is usually oronasal. His breathing is usually oronasal. Okay, that is the reason that we want the oronasal mask to be there. Right? We need that oronasal. So where do you use the nasal mask? If that is the case, we don't need nasal mask anytime. Yes, you'll need it because NIV is also used for OSA, obstructive sleep apnea. When you have OSA, person is sleeping at home. I want to talk, I want to do all these things. Or if I'm just at home, I would rather use a nasal mask. I want to talk. If you put something in my mouth, I can't talk. Right? So if I'm just using it for an OSA, or I'm just using it for whatever small problem I'm having at home, I would use a nasal mask. If I use a nasal mask, I can talk. Some people will, I don't like to put this in my nose, I feel I don't like it. So for them you have a oral mask. For them you have an oral mask. Some people say even this is for me claustrophobic, I have my nasal bridge, it pains me. For them I give them face mask. There are certain indications for each of those things. Right? And then the last one is helmet. Helmet is a device that you put like this all over. We used in COVID, we worked in COVID, so many patients we use with helmet. Right? Helmet device that we use. You also use one or twice helmet. Okay. So but you should understand when you're using a device so different, helmet, because helmet interface we may use in the intensive care unit, oronasal we may use in the intensive care unit. The difference is when you have a helmet interface, you have a huge amount of dead space. A huge amount of dead space. Dead space is that part of the air that doesn't take part in the gas exchange. So there was a huge amount of gas inside that helmet, which you will have to alter the settings to actually manage. Right? So this is what the basic difference you should understand when you look at interfaces. Right? So these are the various interfaces you have. I'll repeat it. Nasal, oral, oronasal, full face and helmet. So whenever somebody asks this question, what kind of interface you require, you should know these. You should know these and you should know when to use what. I can't use an oronasal interface or a person is in OSA at home. Are you understanding? So it's important for us to understand what to use at what time. Then the other thing is ventilators. So what are the kind of ventilators you'll use in these cases? So there are three kinds of ventilators, of which the first thing is the black box ventilators, classically called as black box ventilator. What is black box ventilator? That small ventilator that you have for NIV purposes. The small one, home NIV, that is actually called as a black box ventilator. Okay, what is the black box ventilator? The black box ventilator is the one that you use as a portable NIV for home use. Okay, that is called as black box ventilator. The other ventilator that you have is the usual regular mechanical ventilator. You have a regular mechanical ventilator that can couple as an NIV. Most of the ventilators that we have over here can be coupled into an NIV. Can be made into an NIV, most of the ventilators. But there are specific ventilators that are only for NIV. There are specific ventilators that are only for NIV. That's called specialized designed mechanical ventilation for NIV purpose only. Right? Can we get the respiratory transport ventilator? Clear? Clear on this yet? So what is the difference? What is the difference between the black box and the mechanical ventilator? What could be the difference? Sorry?
Black box is portable.
It's portable, right? It's portable. Number one, it is portable. You're right. A black box ventilator you've seen, the small NIVs that we have, we give it for patients who come into the ICU when they're transitioning to the wards. You have the black box ventilator. So that is, first it is small, it's portable. Then, anything?
More photo requirement.
Sorry?
Photo requirement to set at home.
What is the difference between this? Niharika?
Bi-level pressure is in black box.
Sorry?
Bi-level pressure रहता है उसमें IPAP
इसमें भी रहता है। तो इसमें भी रहता है। हमारे नॉर्मल वेंटिलेटर में भी IPAP, EPAP, प्रेशर सपोर्ट, पीप सब कुछ रहता है। बाय-लेवल तो उसमें भी इसमें भी है। What is the difference? So there are many differences, many differences. One of the difference is the fact that you can titrate your FiO2. In these small boxes, can you titrate or FiO2? No. You just apply it to an oxygen, you give SOS amount of oxygen जो चल रहा है. किधर तो भी लगा देते ऑक्सीजन और देखते हैं कितना चल रहा है. बेसल पंप लगा देते कभी तो लगा देते. We don't know only. Whereas when you're using an ICU ventilator or a specially designed ventilator, you can actually have a blender in place. You understand? जैसे हमने blender बोला था ना, हमने for an HFNC we had a blender. So these big ventilators have got blenders. The blenders give you the right oxygen. समझ में आ रहा है? So you have an attachment to change the FiO2 as per your requirements, which is not there in these small ventilators. Clear? Second thing that is, the third thing that is very important. These ventilators that you have, these big ventilators have got graphics. It's got graphics. You can get a whole lot of data as feedback that comes from there telling us about what is happening to this particular patient. You understand? It's got graphics. Very, very good. It's got graphics, right? That is the second thing that happens. The third thing that happens. Then come on, quickly.
There are expiration ports, the masks are different for the home NIV and
So the interfaces are different, but before that, what is? You're right. We'll come to that. Okay, we'll come to that itself. So there is a difference between the way you ventilate these patients, but that I'll explain to you. These black box ventilators will have a single limb. Whereas your NIVs that you have specialized NIVs, or you have your ICU NIVs, majority of them will have two limbs. One for inspiration, one for expiration. So an expiratory port, expiratory sensor, flow sensor, all these things are there. So you have two kind of ports over there. Whereas what happens in a black box ventilator, you have a single circuit, but the difference is there will be a hole somewhere. The hole will be either on the tubing or it will be on the mask. Either the hole will be on the tubing or it will be on the mask. This means to say the masks are not interchangeable. You can't use the mask of the NIV on the patient who is on home NIV. You understand? Yes. You can't do that. You can't use the mask of your NIV machine and use the same mask for your home NIV. Because the home NIV, if it does not have a leak port, that patient will suffocate with carbon dioxide. This is exactly what happened some years ago when we were in the hospital. We had a patient, very, very nice patient. Patient was very ill. Patient was intubated, ventilated, COPD, very difficult patient. Nice patient also. We celebrated a birthday and all over here. Okay, it was a nice patient. I remember this. Okay, and what happened was we transitioned this patient to a NIV and we said use the NIV in the wards. Use the NIV because COPD hai. We said it will work. You use the NIV in the wards. What happened was this patient went to the ward. They applied the NIV and the patient within 3 hours came back to the ICU. Agitated, not okay, mentation not okay, carbon dioxide at 76, 80, we're not understanding what's happening only. Okay, this patient goes over there and comes back. Transport and ठीक है, clear on this? Have you understood this? So we had this patient who came back. So we came back, we put on machine, patient became normal, patient became nice and patient was transferred out the very same day, same evening patient was transferred out. And we were like, maybe anxiety है, ये है, वो है, चल रहा था. बाकी कुछ नहीं है. रात को थोड़ा प्रेशर्स कम किया इधर किसी ने और बोला किचन लेके जाओ उसको. The same night patient went back. Same evening patient went back. Everything is okay. That night again patient came back. Same situation. Again patient came back. Again they put a machine and then like ये क्या चल रहा है? Why is this patient coming back? इधर तो एकदम सही है. Next day morning patient एकदम normal, completely normal. Like as if she's talking to us and eating food and all normally. Okay, so then we went back to understand what was happening. What was happening was they had taken the NIV of the ICU and they had applied it to the ward. And what was happening? There was no leak port. Since there was no leak port, CO2 retention was occurring, she was getting agitated and then she used to come back down. Because she can't breathe. If you don't have leak, how are you going to breathe? And what was happening in the ward? When she's getting agitated, they're making it more tighter and more tighter. Because they thought that she's not getting adequate air. She is actually suffocating. Some poor lady is suffocating. It was very bad. It was really, really bad. Poor quality of care, poor understanding of everything. This is exactly what is happening. So if you look at it, look at the difference. This is your ICU NIV. Your ICU NIV. In the ICU NIV, what you're having a mask. And there is no leak anywhere. There is no leak anywhere. It's just a mask, usual mask. When I have a home NIV, what am I seeing? What am I seeing in the home NIV?
There is a
and there's more leak, there'll be more leaks.
Side.
See this?
हाँ,
There are leaks. इसमें leak नहीं है. The leak is this one only. I thought this was also leak, but it's not a leak. Okay. Some of them have that leak also. So you need to figure out whether there's a leak. See that there's a leak here. Can you see this? Can you see this? There's a leak here. So sometimes you may find the tubing having a leak. Sometimes you may find that the tubing is having a leak somewhere, a hole over here. It may not be the mask, it may be the tubing. Okay, it may be tubing over here. But this is how an NIV looks. A portable NIV looks, a black box ventilator. So it does not have anything, no waveforms, nothing. It has the same IPAP, EPAP. Whereas this is an ICU ventilator actually. Okay, this is, so when you tell me single limb, dual limb, it doesn't work anymore. That's what you must know. Because even this ventilator is dual limb ventilators. Okay, so you must understand. Okay, the classical black box ventilator had a single limb, but now we have got multiple ventilators that come with dual limbs. Okay, so this ventilator is an ICU ventilator because of the fact that I can adjust the FiO2 here. I can adjust the FiO2. I attach the FiO2 and I have a button here to change FiO2. I have graphics in this. I got dual limb circuit over here, but here I cannot use this one. What do I have to use? The other mask. Clear on this? Clear? So you just set it up. Make us set it up. Okay. So the question is, how do you use it? If I have to now we'll first go to the practical application. As I set it up, we just go to the practical application. Okay. So where will I not use this? Where am I not going to use any of these devices? I'm not going to use any of these devices when there is
secretions, yeah, and just
why? Why would I not use it when there is secretions? Why?
So there's high pressure.
That's okay. My airway is okay. It's high pressure, but I'm awake, right? I'm awake. I just secretions of क्या relation है? Simple, no. You give so much of air through this, what will happen? It will dry out the secretions. Mucus will get inspissated. It will get dried out. If he has to remove secretions, he can't remove it out. You understand? If he has to ऐसा करना होएगा ही नहीं उससे, होएगा नहीं because ये सब इतना हवा अगर जाएगा. So what is the NIV? What is the feeling of an NIV? The feeling of an NIV is you driving at a rate of 100 miles per hour in the car and putting your head out. That is your feeling of an NIV. What is the feeling of an NIV? You driving at 100 miles per hour and putting your head out with your mouth open. Okay, that is the feeling. Like you go on a high-speed train, running at 80-90 kilometers per hour, and you would like to stand outside. You really can't do that because you just can't sit because it's too much of air coming in. That is exactly the feeling that comes when you're using an NIV, right? So, and you have you felt it like this? Have you felt it? Then you should feel it. Today we should feel it. Okay, how it is. Okay, lying we will do it. Okay, so secretions. So secretions, that is one thing. The second thing is an aspiration risk. I'm not going to use it in patients who've got an aspiration risk. For example, a patient is obtunded in cardiac arrest. उसको जाके NIV नहीं लगा सकते हैं. It is a simple no-no. Sometimes you may use it because of some extreme clinical condition like patient with neutropenic sepsis, palliative care, not wanting to do anything. ठीक है, उसमें लगा देंगे. But otherwise, for practical purposes, you should not put it when the patient is having a risk of aspiration. You should never do it. It is not something you will want to do. The third thing is interface phase problem. That means if you have a HFN surgery done or you have a beard, it's not going to work. You got a big beard, it's not going to work. It's very, very difficult. If you have a beard, very difficult because the leaks are too much through a beard. It's too much. You can't use an NIV if you have a beard. It's very difficult. That's why if you have a beard and you want to use an NIV, it's better to ask the relative whether we can shave him. Okay, otherwise you will not be able to use it well. वो नहीं होता है use. If you have a big beard, it's very difficult to do that. Very difficult. I was also having a difficulty when I was using the NIV. When the NIV was put for me, I was not able to breathe at all through that. It was very difficult for me. ठीक है? Because वो बचता रहता था. And what happens is if you have a leak, you have set a pressure. The ventilator tries to deliver that pressure. So what does it do? It increases the flow. It gives more flow. So what happens is if there's a leak, I am set a pressure of 10, okay, and the leak is there. Put 10 pressure maintain करने के लिए it will increase the flow, and my eyes and my nose and everything will be in a problem. It will go into my eyes and all extremely. You understand? This is what occurs with that kind of flows. So leak cannot be tolerated. That's the problem. So interface phase problem is an issue. And obviously, as I told you earlier, I will not use it in multi-system organ failure because the chances of failure of NIV is alarmingly high when you use it in multi-system organ failure. Right? So that comes to the settings. Okay. What are the settings for the heart? The settings for the heart would be the maximum tolerable CPAP. Maximum tolerable CPAP will be what it is. Okay. So if I have a patient who is on the ventilator, who's an NIV patient, what I will do? I will take this and I will first, how do I apply the NIV? Switch on किया? On किया ना? On कर इसको CPAP पे on कर. Unlock CPAP. So apply the ventilator. Apply to Nehariko or Ankit or somebody. Let's apply. Atul को लगेगा. Nearby. Hello. Give him the chair. Let him come in. Low pressure. Okay, started at low pressure. And let him breathe. Apply. Now the pressure is a little bit better. And then go slowly higher on the pressure. Go slowly higher on the pressure till he tolerates it. So 8 or 9 or 10 he will be tolerating that pressure. And that would be the right pressure when you're looking at cardiogenic pulmonary edema. Now the question that comes is, do I use bilevel? Okay, this is only CPAP. Okay, now if I want to use bilevel, say for example he's breathing, but his tidal volumes are very small. His tidal volumes are 150, 200, 250. He has bilateral pleural effusions. He's got pulmonary edema. That's why his tidal volumes are on the lower side. So you want to increase that tidal volume. To increase the tidal volume, I will add pressure support. So if I want to add, if I see his tidal volume here to be 150, I'll probably add 2 or 3 of pressure support. When I add that 2 or 3 of pressure support, what is going to happen? His tidal volumes will start going higher and higher. You understand? Otherwise, if his tidal volumes on the lower side, what is going to happen? Carbon dioxide retention will take place. You understand? That's why this is what I'm going to do. I may use directly by PAP also. But the point is, whenever you're trying to use a ventilator, one of the easiest techniques is tell the patient to hold the ventilator. Tell the patient to hold the mask. The easiest technique is that. If the patient is, you want to start the patient NIV, tell the patient, आप mask पकड़ो, खुद पकड़ो mask. And then धीरे increase. You must tell them that काफी हवा आएगा, आपको मुंह खोल के आराम से श्वास लेना है. And then as he's going to breathe, you will see here. What are you going to see here? Whether he's triggering the ventilator. Okay, what are you going to see here? So if you're putting the CPAP, I'm increasing my CPAP. 1 हो गया, 2 हो गया, and whether the ventilator is giving that. अभी मैं pressure support लगा के रखूँगा, लेकिन मैं CPAP बढ़ाते रहूँगा जब तक कि वो trigger हर breath को नहीं करता है. Okay, हर breath को trigger करेगा तो its trigger is not there in the ventilator. There is no trigger. The trigger here is your EPAP. Your trigger here is your EPAP. Your IPAP is your volume. You understand? दूसरे पेशेंट में वेंटिलेटर में क्या होता है? ट्रिगर है, इसमें ट्रिगर नहीं होता है. And then this is how you will monitor your patient. This is how you will attach your patient on the ventilator, right? So the ideal option is patient is lying down, my hand is on his abdomen, and I'm slowly increasing my EPAP. So as I feel my hand is going up, my EPAP will triggering the ventilator. This is fine. This is okay. Now I do whatever I want to do with respect to cardiogenic pulmonary edema. Then I look at my volumes. Is my volume okay? If my volume is low, I'll increase my pressure support. You got the point? If I have a leak, there is no point of doing all this. If there is a leak, so I don't need a big leak. I don't need a small leak also. I need a normal. A normal leak is okay, because what is the difference between invasive ventilation and mechanical and non-invasive? Non-invasive ventilation has got something called leak compensation, which is not there in invasive ventilation. Right? You understand? There's a leak compensation. Right? Leak compensation. So the air is too much. When you see it, when we started it, Atul, when we started, the air was too much, right? Yeah, so it is very difficult. So tomorrow if you take a patient and you set, if you take a patient and you say, I'm going to set IPAP at 10, IPAP at 4, and I'm going to go and attach it to the patient will get hair like that. You understand? You can't go and just put it on the patient. Patient will not like it at all. Your compliance will go down starting only. You understand? So when you're starting, start at 0, go up slowly. You understand? Start at 0, go up slowly. Clear on this? Start at 0, go up slowly. Clear on this? If you directly apply, it will be too much of air coming inside. Patient will immediately say, I can't use this anymore. It's very important that you feel this, okay? It's very important. And this is just a smaller one. If you look at the bigger ventilators, it will become very, very difficult for you all. Right? So, what is your answer now? So, maximum tolerable CPAP is what you require. But in the event that the tidal volumes are on the lower side, I may want to use bi-level. And it is known that if I give bi-level, there is a little bit of effort that is reduced. A little bit of the effort will be reduced. If the patient is highly effort dependent, very highly effort, is making very big effort, you can probably start a small dose of pressure support also. It will help you because more the flows, lesser the effort, more the comfort. Clear? So now you've understood the level of IPAP and EPAP that I'll use and how will I use it? You've understood, no? For cardiac cases, you understood this, right? You understood this, right? So this means my graph, how will my graph look here? The same graph. The same graph will look something like this. So this is your, what is this? This is bi-level. This is bi-level. So I have an EPAP, I have an IPAP and I have a pressure support, right? I have an EPAP, I have an IPAP, I have a pressure support. This is my starting. I started at a bi-level now in this patient. Okay, now it has been some time and the patient is not improving. Patient is not improving. What do I do here? What will I change on this? IPAP, EPAP, PS. What do I want to change? You can call it whatever you want, IPAP, EPAP. So patient is not improving. Patient is still breathless. Patient is not doing well. You have a bi-level positive airway pressure. Atul, you have a patient. Patient has come with cardiogenic pulmonary edema. Patient has cardiogenic pulmonary edema. Systolic dysfunction, heart function is 25%. Patient is breathing heavily. Patient, you have done an ultrasound. Ultrasound shows multiple V lines and V profile all over the lungs. You know this patient is classically in systolic dysfunction causing heart failure. And you know that if I were to give pressure, positive pressure, my 2T of an hour will change, my afterload will improve. But the patient is not improving, it's been 10 minutes. You have applied it, but patient has been 5 minutes, 6 minutes, there is no change. Pulse rate has remained the same, patient is agitated. What will you do? Because we need to understand how do we change the settings, right? So what do we do? Because you are not having any number to look at. The number is, pulse rate has been 120, saturation is still remain 90. What do I do? Patient is not improving, what do I do? What do I change here? I have to change something, right? What do I do? Sorry? I have got both EPAP and IPAP. So let's take, what do you want to change? Okay, what will happen if you change EPAP? We understood that. But what will happen to the pressure support if you change the EPAP? The pressure support will decrease. It will decrease, not increase. It will decrease. So if the EPAP goes up, the pressure support will decrease. Your pressure support will decrease. So what will happen to your tidal volumes? So that is not the right answer. समझ में आ रहा है क्या होगा? If you increase the EPAP, what is going to happen? The pressure support will decrease because at the end of the IPAP has remained the same. So pressure support will decrease. So if your patient had a tidal volume of 200, it will become 100. If it is something like that. You got the point what I'm saying? Ventilation will become an issue. What do I do? Sorry? You will increase the IPAP, but then what have we discussed just now? The patient's afterload will come down only if the EPAP increases. So our treatment is for what? For cardiogenic pulmonary edema. So by increasing my IPAP, I am not doing anything.
Both we will have to
Increase the
Yes, the answer is that. So in cardiogenic pulmonary edema, I will have to change both. So it will be like this. You understand? I will maintain my pressure support. I will maintain my driving pressures, and that is how I will keep changing it. You understand? So it doesn't improve here also. I will change it again. But what is the constant here? The constant is the pressure support. What I am seeing here is the constant. That is the constant. You understand? So if I have a cardiogenic pulmonary edema, I have started at 10 and 5, and the patient is not improving, I will make it 6 and 11. I'll make it 7 and 12. I'll make it 8 and 14. You understand? But I'll need my driving pressure to be the same. In effect, what have I done? I have maintained the tidal volume. But I have increased the EPAP so that I could reduce my afterload. Clear on this? So big difference when you look at cardiogenic pulmonary edema. Right? You understood how to change the settings in cardiogenic pulmonary edema now? Any doubts here? Any doubts yet? Any doubts? No, right? Okay. Now, that's the importance of having EPAP and a driving pressure. That pressure support that we are calling is called as driving pressure. Right? So this is the importance of EPAP. Is important of driving pressure. Right? Now, what about lungs? In the condition of lungs. In the condition of lungs, what really occurs? What is the EPAP? What is the driving pressure? Let's see a patient of COPD now. We said cardiogenic pulmonary edema. The next patient is COPD. Alright. उसको बोला नहीं उन्होंने बारी है ना बोलो उनको अंदर बोला कराने में हाँ so अभी मेगा wait I think you need to wait इधर ये होगी ना आप क्या So you have pressure support and time here, right? So here you have a patient who is basically coming to you with a CO2 of 55 or 75. Patient is conscious, but patient has got a high CO2 and is developing an acute exacerbation of COPD. Breathing heavily, and saturations are 88, 89. You have attached ventilator at 10 and 4. Let's take the example of 10 and 4. Okay, and what is happening to a COPD patient usually? What is happening? The COPD patient, what is happening to a COPD? What is inside the lungs of the COPD patient?
Destruction of the
What is
air.
happening? What is the mechanics of the lung? What is happening?
FRC is increasing, dynamic hyperinflation is there.
Very good. So there is what is dynamic
Auto-
hyperinflation?
Due to incomplete exhalation because of the airway, inflammation of the airway, there is a increase in FRC, which is
Yeah. So what is happening is your lung volume is already big. Your lung volume is already big. Because what is happening? You normally what is happening in your body? You are expiring. You are expiring because the elastic is very good. Elastic compliance is very good. So what is happening is inspiration is active, expiration is passive. That expiration passive is occurring because the joints between your alveoli, your interstitium, all those areas are beautiful. That's why it tucked like a rubber band, it goes down and you expire. Right? But what is happening to COPD patients? Their lungs are spoiled. So rather than actually going back to that expiration, it just stops there. So it is not able to take off that or CO2 or the air. It is unable to take off that CO2 or the air. Okay, that means the patient has got air inside. It's not coming out. And then what is happening? He is getting an acute exacerbation. That is because he had some infection, some LRTI, some anxiety, something has occurred, which has caused this patient to breathe faster. The only way he is breathing out the carbon dioxide is by breathing slowly. When he breathes slowly, because it's passive, no? He's breathing slowly, so that I ratio keeps changing, because of which he's able to breathe out. He's able to breathe out. Slowly with passive diffusion it is going out. Actively नहीं हो रहा. जैसे actively हमारा हो रहा है, elastic loads are so good that we are actively breathing it outside. वो बेचारे को नहीं हो रहा. It's not able for him to do it. So he needs to be breathe slowly. Now he gets anxious. He gets an infection. He gets fever. What's happening? He's breathing
fast.
so the effective expiratory time is actually reducing. Since the effective expiratory time is reducing, if he is unable to get off the carbon dioxide. Not only that, because of that situation, what is also occurring, you would say, okay, he's not getting off, so he'll breathe even more heavily. He'll breathe more heavily. He can't breathe that heavily because what has happened is his diaphragm has now become like that. Because धीरे धीरे वो inflate हो के उसका diaphragm ही ऐसा flat होने चालू हो गया है. Since the diaphragm has become flat, he cannot develop that kind of load. He is not able to produce that kind of load. You're understanding? He is unable to produce that kind of load. And since he is not able to do that load, that is when he is landing into your intensive care unit. He is unable to take it out. You understand? The diaphragm has become flattened. Very difficult for him to do that. You understand? And that's called as dynamic hyperinflation. Dynamic because at the active expiration also nothing is coming out. Okay? He is unable to get that out. Right? All this can be called in various terms. It can be called auto PEEP, it can be called eye PEEP, it can be called as intrinsic PEEP. The pathology is dynamic hyperinflation, but what is developing inside is auto PEEP, eye PEEP, or intrinsic PEEP. Clear on this? Clear on this? The pathology is dynamic hyperinflation, but the terminology for that pressure inside is called as eye PEEP, auto PEEP, or whatever you call it. Clear? So now this is that patient. This is that patient. What do you do in this case now? He's worsened. This is what his condition was. You have put him on 4 of PEEP and 6 of tidal volume, 6 of pressure support. He worsens. He's not improving. What do you do in this case? Sorry? Q? You're right. Q?
पीस करना ऑटो पिक कम करना है.
His problem is he can't breathe only. इतना भर गया है कि वो breathe ही नहीं कर पा रहा है. Breathe ही नहीं कर पाया. So no ventilation at all. Zero ventilation. I need to improve his ventilation. And to improve, I don't have a problem with oxygenation. EPAP was oxygenation. I have a problem with ventilation. If he's getting hypoxic also, I might increase my EPAP a little bit. I might increase my EPAP, but what am I increasing more? I'm increasing my EPAP more. You see? But I might increase my EPAP a little bit. But what am I increasing more? I'm increasing my IPAP. Are you understanding? So in this case, if their oxygenation is not a problem, मेरे को EPAP कुछ करना ही नहीं. Okay? And if the patient triggering the ventilator, मेरे को EPAP से कुछ करना ही नहीं. अगर पेशेंट वेंटिलेटर ट्रिगर नहीं कर रहा है तो मैं थोड़ा सा ईपैप बढ़ाऊंगा, but I will increase my pressure support more so that I can offload the lungs, so that I can give the diaphragm an advantage, so that I can ensure that air moves in and moves out. Clear on this? So the difference in the management would be, in this patient I would see, say I put at 4 and 6, I would say okay, he's triggering all the, he's triggering each and every breath, so that 4, let that 4 remain the way it is. The 4, I'll increase the 6 to 8. I'll say try volume 300, oh no, this is okay, 350 is coming, this is fine. So I've made from 6 to 4, 8. He's done well. Now repeating another patient, 4 and 6, no trigger. It's not, ventilator is unable to trigger the breath only. Why is not able to trigger? Why is not able to trigger? I'll explain this once more to you. Okay. So I have a patient on COPD. What has happened over here? This is my alveoli. The alveoli has become like this because it's auto peep. He's developed that inside. Ventilator is there. His alveoli is there. So now, if the pressure over here is positive, let's take the pressure as plus 8. When will air come from outside to inside? When this pressure becomes negative. When this pressure becomes negative,
yes.
then only air can come from outside to inside.
Yes.
Clear? That means he has to breathe minus 8. He has to breathe minus 8. It's only then that the pressure will come from there to here. Right? Then only the ventilator can trigger. Then only the ventilator can trigger. If it does not reach minus 8, the ventilator will not sense it only. Ventilator will not give the breath only. You understand? Clear on this? So what am I going to do in this case? If by any chance I can't do this to minus 8, I'm going to add say 6 over here. If I add 6 from here, the difference between this is only 2. So I need to only make minus 2 here. Are you understanding what I'm saying? I just need, because I already given 6 over here. So I need only minus 2 here. Understood or not? Nice one, no? So I'll explain this again. Normally what is happening? Normally this is your alveoli. This is your alveoli, normal. Normally at the end of inspiration, this is 0. It's 0. All of you sitting in this room are having a minus 4 approximately inspiration. A minus 4. So this pressure over here becomes minus 4. So when it is being minus 4, you and I am moving air from outside to inside. My air is now moving like this. Clear? I am generating minus 4. That's why air is moving from outside to inside. Mechanics is such that negative pressure is inside, positive pressure is outside. So air is moving from outside to inside. Simple. Now what is happening to the COPD patient? It's become bigger. We just explained why it became bigger. It became bigger because air is just accumulating. It's not coming out, not coming out, not coming out. This is called dynamic hyperventilation autopy. So this means the pressure inside is no longer 0. The pressure inside is positive. So let's take it as plus 4. Let's take it as plus 4. There is going to be something inside. We don't know how much it is. Maybe 4, maybe 5, maybe 6, maybe 10. I don't know. Now for air to move inside, I need to make this minus 4. I need to make this minus 4. अभी इसको minus 4 करने के लिए इसको क्या करना पड़ेगा? पहला plus 4 generate करना पड़ेगा, फिर minus 4 generate करना पड़ेगा. मतलब minus 4 मतलब इसको how much has to generate minus 8. Understood this? अभी उसको हवा अंदर घुसाने के लिए he will need 4 minus 4 because minus 4 required for air movement.
Yes.
समझ में आ रहा है? हाँ. So you'll have to have minus 8. नीचे effort ऐसा करके तू ही हवा जाएगा. You understand? अभी हम लोग को क्या करना है? We have to make. So that's why he has to have minus 8. जब तक वो minus 8 नहीं करेगा तब तक हवा अंदर जाएगा ही नहीं. So that means the ventilator will not give the breath only. Ventilator will not give that kind of breath. I want to ensure that the ventilator is giving a breath. That's what I explained to you about EPAP and trigger. EPAP and trigger. So what I will do? I will increase my EPAP over here. Make it. I will put EPAP of 2. When I put an EPAP of 2, ये pressure है कि इधर नहीं है, इधर है. Mouth पे है. It's not down here. It's here. Right? So I make this. If I make this 2, what happens is 4 है ना इधर. ये 2 ऊपर है. So I just need 6, no? Minus 6.
Yes.
You understand?
Yes.
Now I will make this 4. When I make this 4, I need minus 4 only.
Yes.
Now my patient will get that breath because it is able to trigger it. समझ में आ रहा है? Clear on this?
Yes.
So this is how you counter auto peak when it comes to COPD patients. That's why what I'm going to do, I'm going to keep my hand on the abdomen and I'm going to look. Okay, there is a movement of my abdomen. That means patient is triggering, but there is no breath on the ventilator. There is no breath on the ventilator, but there is no breath coming in. Why is no breath coming in? Probably he's not able to trigger the ventilator. So what do? I will increase my
EPAP.
EPAP. I'll increase my EPAP to an extent. Oh, I'm triggering now. समझ में आ रहा है ये? Have you understood this?
Yes, sir.
That is how you look at EPAP. Right? And because my problem is, I want to ventilate my patient also because he's unable to move in air, I want to add pressure support. Now you understood my EPAP and my IPAP settings?
Yes, sir.
So see the difference between cardiogenic pulmonary edema and NIV? What is the difference COPD?
Yes, sir.
You see the difference? It's very beautiful, it's very pretty if you understand what it is. If you don't understand everything, just put anything. You have to understand it. That's the beauty of everything. And then you cannot just, I cannot just say like this, it's so simple also. You have to stand with the patient, understand what is happening, alter it to understand. You cannot just put a setting and go. This patient is not doing well, chalo increase, dono saath increase kar lo. Aisa nahi hota hai. Stand with the patient and see what happens when I do that. If the intended effect occurs, then my setting is right. You can't just put the setting because Dr. Sanjay told to do that setting. It doesn't work like that. You understand? That is the reason that as a clinician you are supposed to work. Right? Clear on this? The next question that comes over here. Understood any questions on this? On the settings between cardiogenic pulmonary edema and COPD on an average? So this same holds good for acute respiratory failure. So in acute respiratory failure also, I will look at my pressure support, look at my EPAP, and then what will I do? I will probably increase my EPAP based on the oxygenation, increase my pressure support based on the tidal volume. I will increase my EPAP based on oxygenation. And why EPAP will improve oxygenation?
Triggering.
No. Why will EPAP improve oxygenation? I just now said two important words. I said pressure support or my EPAP will change my tidal volume, whereas EPAP will change my oxygenation. Why does that happen?
The alveolus open at the end.
So when you are working, when you are actually breathing, when you are breathing, you have inspiration and you have expiration. You have both.
Yeah.
So when you are inspiring, your alveolus is like this. When you are expiring, your alveolus is like this.
Collapse.
Okay, gas exchange will take place only and only when your alveolus is open. Only in inspiration. That means only in a patient 25% of the times you are actually having gas exchange. Oxygenation. Oxygenation is going to occur only when your alveoli is open. Oxygen will move in only when your alveoli is open. Oxygen will move in only when your alveoli is open. If your alveoli is closed, oxygenation is not going to occur. Just like how we have in collapse. In collapse, what is happening? One lung is collapsed. Oxygenation is dropping because there is no oxygenation happening. Collapsed ho gaya alveoli. Right? Now, so that means to say, in my average breathing that you are all having over here, 25% of the times only you are actually oxygenating. You are oxygenating only 25% of the times. 75% of the times you are not oxygenating. It's expiration is going on. 1:3, 1:4 is going on. You understanding now? What do I want to do? I want to keep this open for more time. If I keep this open for more time, oxygenation will improve. If I keep it open for more time, and that's exactly what EPAP does. That is exactly what EPAP does. समझ में आ रहा है? So that's why in acute respiratory failure, if I keep it open for a longer period of time, the oxygenation improves. That's how PEEP works. Okay, clear on this? It doesn't collapse. So if I have a patient without PEEP, inspiration, expiration, inspiration, expiration. If I have PEEP, inspiration, expiration, inspiration, expiration. There's a difference. It remains open. Clear?
Yes, sir.
Clear? And that's how in acute respiratory failure you adjust your settings based on oxygenation and tidal volumes. So IPAP would be tidal volume, EPAP would be oxygenation in acute respiratory failure. So you've understood how to manage COPD versus cardiogenic pulmonary edema versus acute respiratory failure?
Yes, sir.
Right? The next question that comes is, when do I use what? I got both. I got the NIV, I got the HFNC. So what's your thinking? When will I use HFNC? When will I use NIV? Anybody? Kadapa? We have both. In the ICU we have both. What are you going to use and when? Let's not put cost into this equation. Let's just ask whether what exactly we're going to use.
cardiogenic pulmonary edema, NIV.
Very good. Which NIV? CPAP or HFNC? CPAP. Right? So he wants to use, Kadamba wants to use cardiogenic pulmonary edema with CPAP. Okay. Anybody else? Anything else? Anything else? Where you want to use? You have got multiple indications. Neuromuscular junction, COPD, pneumonia, what? So, Sakib? You just shake your head, don't tell me anything. You have to first tell me, then shake your head. Okay, I'll go ahead, okay? So first, the question is need to tube. Huh? So if you need to tube, you just intubate. That means if a patient is having cardiac arrest, if the patient is having aspiration, if the patient is completely down and out, if this patient is in hypercapnic respiratory failure, there is a need to intubate. Patient has trauma, multi-system organ failure. There is no point of NIV and all. Need to tube the patient. Don't try anything. It doesn't make any sense. Don't try. Put the tube in. It is more safer than actually not intubating your patient. Okay. The other thing is, then you start thinking if there is no need to intubate. For example, there is at this moment no need to intubate. I have a patient that is like bed number just now whom we intubated. Okay. That patient I'm there. Okay. Maybe he's maintaining his airway. Okay. His oxygenation and there's no need to intubate. Then I find out what is the pathology. I find out what are my contraindications. I will say, okay, patient does not have secretions, patient's aspiration risk is not there, there is no interface problem. These three things I can't, no? These three things I can't intubate, I can't put an NIV. So I see these three things, I say, okay, there is no phase problem, beard is not there, aspiration risk, there is no HFN surgery done, the patient is conscious, the secretions are not excessively, it's not that he's got bharbarke secretions. What do I do in these cases? I will give an HFNC trial. Okay, I'll give an HFNC trial. Okay, if you have any of these contraindications and this patient is either heart failure, COPD or neuromuscular junction blockade, this patient will require a BiPAP trial. Because we know that in BiPAP this works very well. We know that cardiogenic pulmonary edema, COPD and some cases of neuromuscular junction blockade, the BiPAP trial is what you give. Now you start the patient on BiPAP and patient is not tolerating that BiPAP, compliance is not there, patient is removing the mask, patient is not doing well. I need to give some positive pressure because I know positive pressure is going to help my heart. I know positive pressure is going to help my heart. But the patient is not taking the BiPAP. Okay, then I will give positive pressure using HFNC because HFNC can give you up to 5 to 8 millimeters, so 6 to 8 millimeters of mercury of PEEP, 6 to 8 of PEEP दे सकता है. Up to 6 तक दे सकता है with mouth closed.
Yes.
In the right settings with mouth closed, I can reach around 6 to 7 PEEP. I can reach 6 to 7 PEEP. And why do I want to give that PEEP? Because we just discussed CPAP helps patients, right, of pulmonary edema. So I will want to give that. So if I try BiPAP and BiPAP is not working, okay, then I will use what? I will use HFNC here. Clear? Just tell the Rishi to call him. Mr. Rishi to call him. Alright. Now, if the question that comes over here is, can we use BiPAP if there is any other indication, like it's a lung indication. If any other indication, use HFNC. It is not heart failure, it is not COPD, it is not neuromuscular junction, it's pneumonia, for example. If it's pneumonia, let's not use the BiPAP because we know in pneumonia it doesn't work, secretions have to come out. We need the patient to be not getting self-induced lung injury because if I give more pralicolium it will cause more problems inside. So I will use what? HFNC. Now I don't know only what this patient has. I don't know only what this patient has. If I don't know at all what this patient has, the right option would be HFNC. If I don't know at all, because BiPAP I know works very well only in cardiogenic pulmonary edema, which I can easily find out, a COPD which I can easily find out, and neuromuscular junction which I can easily find out. If I don't know it's none of these three things, what is the mode I will use? HFNC. Clear? So this becomes very simple for you.
Yes,
I have tried to simplify it as much as possible. Okay, so that it is very easy when to use what. क्या use करूँ ये question आता है ना, तो क्या use करूँ मैं, ये ऐसा सोचने का. समझ में आ रहा है? Unfortunately, there is one big element in India that comes in is cost. So you have to think hard before doing this. Okay, and if you are doing, you have to think hard on this also, right? Complete this entire whatever we talked about. Okay, there are a few things. One is best intervention in mechanical ventilation is non-invasive. Correct understanding of working principles we require. Without that, there is no point of you doing anything. Okay, but both improves outcomes. Both NIV and HFNC both improves outcomes. Correct monitoring is very important. There's nothing better than correct monitoring. Okay, and don't try to delay the intubation, because what we know is that if you delay intubation, patients die. If you have to put the patient on HFNC and later on convert to intubation, that patient will probably die. If you have a patient on NIV and then later on you have intubated after some 10 hours and 12 hours, that patient will probably die. So we cannot delay the intubation. That means to say the ROX has to be followed. The ROX index has to be followed. If the ROX index is good, HFNC we continue. If it's not, intubate. Because this patient, if you what is known is if you intubate late, that is at the time कि सच में intubation लग रहा है जाके intubate कर दिया, then you are going down. You understand? Then that patient is going to go down. Any queries on this? Any queries? Right? Stop that.